despite controlling all these and despite taking more than a few medications, the patient may remain just excuse me. So about 13% of the patients that you and I treat are not at target, and the nephrologist actually faces most of the issues because 50% of the people attending the nephrology clinic are not at target. So I think they are the ones who are probably using 4 or 5 different group of medications, optimizing them and going up on medications. Generally, when you have such a patient in front of you, the interventionist is looking for renal artery stenosis as a possible cause. Coarctation is something which can be treated, and patient can get rid of his hypertension. And also, we should not miss pheochromocytoma. In fact, this is one diagnosis which all of us feel very proud about if you diagnose, especially if somebody else has missed the diagnosis. At the same time, the pseudohypertension, where the patient's compliance may not be there, patient is not taking medications, you're not using a correct adequate size blood pressure cuff, etc. All these issues also need to be addressed. You can see here, this was a young lady. She was thought to have aortoarthritis for almost 20-25 years. She was taking hypertensive medication. And you can see the left renal artery is completely occluded, right is showing critical disease, and there was an occluded right iliac disease. So actually it was a very premature atherosclerosis that she was suffering, and lipids were exceptionally high and so on. So we stented both, and blood pressure improved to a great extent. So renal artery stenosis is something which should always look for when you're looking for a difficult to treat hypertension. So how do you manage? I think all of us should assume that we have excluded causes of secondary hypertension, and then we focus on managing the options. So optimizing the dosages, I think this is one thing which is very important. The good news is that in red bars is the same drug which is used in double the dose. Like you increase atenolol 50 to 100 milligram, while in these lighter bars you see combination tablet with thiazide, and same holds true for all the combinations. So combinations actually are almost 5 times more potent in getting the blood pressure down compared to doubling the dose of an individual tablet. So combination is something to go by. Now when you move from 1 to 2 and maybe from 2 to 3, again you see this first column is where you see three tablets used in a combination, and again a combination could be very effective. So always try and use combinations. We always had these 5 or 6 groups from which we picked up medications. In 2007, we were allowed to use any of these combinations, but in 2009, as you see, beta blockers is gone, alpha blockers is gone. So these are groups which are not liked by especially the Europeans, and the Americans are also now following. So you are left with diuretics, ACE and ARB, and the calcium channel blockers. So you could use a combination of these to get to the target. What combination you use depends on what associated disease patient has, whether he has CKD, whether he has diabetes, and so on. But generally, the combinations would be quite effective using ACE with diuretics or calcium blocker with ACE inhibitors. And when you need 3, these 3 are the ones which will be combined: the calcium channel blockers, the ACE inhibitors, or ARB, and the diuretics. So we all know about polypills, so maybe some of these hypertensives should have something like a polypill, all 3 combined in one, and we have so many of them in India available to us. This actually increases the patient compliance, forgetting the tablet, difficult regime. These are the issues which can stay back. Then we also talk of strategies of sequential blocking. Now we have these nephron blockade versus RAS blockade. And in this particular phase study, the spironolactone is used, and this is compared with ramipril. So ahead of ARBs, the nephron blockade was quite effective. So you would use nephron blockage in form of spironolactone. I think this is one step which many of us don't do. Like we all believe that all diuretics, low dose, are same. So we moved from hydrochlorothiazide to maybe chlorthalidone as an upgrade. But spironolactone is something which we must learn to use. And there is this study which also says that instead of spironolactone, if you're using aprenolone, many of us believe that aprenolone is just spironolactone without gynecomastia as a side effect. But this is not true. It is clearly a more effective antihypertensive medications. One of the negatives which they talk about when they talk of RDN therapy is the spironolactone was not used when they were comparing RDN with the other therapy. So this is something which we must remember. And then there are these newer molecules which are available in the which are in the pipeline. So we have angiotensin and ARBs compared with the neprisilin inhibitors. We have to wait for these results. And finally, we come to devices, which is actually going to be the core of my today's presentations. So initially there were these baroreceptor blockade. You put a pacemaker kind of device which would deactivate the baroreceptors, triggered hypertension. And there are studies which actually indicated that the treated group was doing better than the control group. However, this never gained popularity. What has really exploded in last 2 years is the RDN, or what can be called as a renal denervation therapy. In renal denervation therapy, what we are trying to do is the nerve endings at the origin of the renal artery, you sort of ablate them with electrophysiology kind of catheter, and this catheter would sort of axially touch these particular points along the lumen of the renal artery so that the nerve endings are ablated. So this is how roughly it is done. You put a catheter from the groin, it will look into the renal artery, the ablation catheter comes out, and you can see you move it backwards and touch many spots along the course of the renal artery. As we know, we have afferents as well as efferents. Both obviously get obliterated. The efferents are probably more important as a cause of hypertension. So once you ablate them, you would see a more appropriate drop. So desirable reduction of global sympathetic tone is achieved by this RDN therapy. By blocking the efferents, we are actually reducing the inappropriate renin release, reducing the salt retention, and increasing the renal flow, and thus overall improving hypertension. How do you judge it that the RDN is going to work? Most of the time, hypertensives who have high MSNA. MSNA is the muscle sympathetic nerve activity. Now, if you have a high sympathetic activity, the renal denervation works. So typically, I would imagine you have a younger individual, say, who is about 40, has difficult to treat hypertension. You already used 2 or 3 antihypertensive medication, and also has tachycardia. I think it's a very important marker where it is going to be effective. It's not to say that those who have controlled heart rate, it will not work, but it works better with those who have a faster heart rate. And you can see from baseline there's a clear-cut reduction in the MSNA once you do RDN. So this is, I mean, there is no blockage in the renal artery. So in terms of angiography, there is nothing exciting. So the procedure would take a few minutes. You end up with a procedure like that. But what you see at the end of 1 month follow-up is probably an improved distal perfusion of the vessels, and thus improving the blood pressure. I'm just going to show you a small animation of how it is done. So these are the nerve endings that you can see, and we'll have to ablate these nerve endings going for about 1.5 inches into the renal artery. You can see this is the catheter tip. It can be controlled from outside. You rotate this so that from inside the catheter tip actually moves, and you touch these various spots along the axiality of the renal artery, and thus you achieve the renal denervation. Now, is this something very new? Actually, they have tried surgical denervation almost 30 years back, but surgery had a lot of problems. There was increased mortality, bladder dysfunction, erectile dysfunction, and orthostatic hypotension as the major side effects. So after a gap of almost 30 years, the renal denervation has been revisited non-surgically. The first-in-man study was published in Lancet and followed by the Simplicity Hypertension 2. This is actually the results of the first-in-man study. You see a drop in the systolic as well as diastolic blood pressure, and it sort of persists for many months after you're done the procedure. The Simplicity Hypertension 2, the inclusion criteria was actually those who had more than 3 antihypertensive medications and yet were having systolic pressures which were more than 160 for regular individual, and for diabetic it was more than 150. So these were the inclusion criteria, and at the end of RDN you see almost a 32 millimeter drop in systolic pressure, 12 millimeter drop in diastolic pressure, while the control group was also on medication, did not show any significant drop. There were no serious side effects, very easy to understand. Whatever side effects were there, they're mostly procedure related that you and I faced during temporary pacemaker because it's a venous side pacing. So basically, there were no sort of issues like renal artery dissection, allergic reaction, etc. However, what people wondered whether it would produce any endothelial injury, that again is not there, so there is no endothelial injury. And people also wondered whether this can be a one-time procedure. That means you do it once, and whether it is going to last whole length for somebody. So it again sort of asks us this question, whether the effect is going to be sustained. This is actually the 3-year follow-up of the Simplicity 1, which was the first-in-man study. And you see that at the end of 3 years also, the blood pressure drop is fairly effective, which means that this is something which is going to last. This is the benefit seen in Simplicity Hypertension 2, a 6 months follow-up, and the drop actually is getting slightly better as time goes. So it's not just that the drop will be achieved, but it will sort of get better as time goes. So it's going to be something which is going to stay there. Now, this Simplicity Hypertension 2 excluded those who had GFR which was less than 45. Now, this is important to remember that those difficult to treat hypertensive who have low GFR, they were not included in this study. So as of now, we don't have data which tells us how those with CKD would behave. We are already into Simplicity Hypertension 3 trials. The results are awaited. How does it compare with medical treatment? This is the spironolactone in addition to all other antihypertensive medications, while this is with RDN, clearly a better drop in the systolic as well as diastolic blood pressure. What Simplicity Hypertension 2 showed was actually change in the range. Like before the procedures, a large proportion had a blood pressure which was more than 180, and this percentage from 39 shrank to around 6. Those who had around 140 blood pressure, they were about 10%. This improved to around 39%. So overall, those who had very high pressure, they dropped to moderate range, and those who had moderate pressure, they dropped to a mild range. So blood pressure became easy to control. So what can be the possible indications for RDN therapy? This is actually systolic pressure more than 160 despite 3 antihypertensive medication tried for 6 months' time. For you and I, this becomes an indication. But let me also add that younger individuals, those who have tachycardia, they are the ones who are going to respond better to the oral therapy. The renal artery anatomy may have some positives before you say yes, it can be done. The diameter should be more than 4. Let me tell you that the renal artery is generally around 7 or 6 millimeters, so 4 is generally never an issue. Then there should be no renal artery stenosis. There should be no previous renal artery intervention. And earlier this one renal artery was considered to be an indication. But even if you have more than one renal arteries supplying one side of the kidney, the patient can be accepted. And as I mentioned to you, those who have less than 45 GFR were excluded in Simplicity Hypertension 2 study, but maybe as time goes, it could be an indication for, that is something which also may be accepted. The RDN actually has moved a step ahead, and apart from controlling hypertension, it has shown some other benefit, and one of them is actually control of sugar and the insulin-related resistance. So this has shown that the fasting sugar is improved with RDN therapy and RDN therapy. Then it has also been found to be effective in sleep apnea. See, majority of the sleep apneas are associated with hypertension. So again, a difficult to treat hypertension, RDN done primarily for hypertension. But they found that once you do RDN, there was of course a drop in the systolic as well as diastolic pressure, which was sustained to 6 months. But in addition, the AHI, which were before and AHI afterwards, also improved. So the dipping which took place as a natural history of sleep apnea syndrome improved with RDN therapy. What about heart failure? The RDN is expected to find some role in RDN therapy. It has already shown that heart rate improves after RDN therapy. And as a adjunct of this, studies are going in the direction that we will probably find RDN very effective. So apart from difficult to treat hypertension, RDN will find its role in sleep apnea syndrome, diabetes, of course diabetes associated with hypertension, and it would have some role in hypertension and chronic renal dysfunction. So as we sort of look at the nervous system responsibility for hypertension, you realize that the essential hypertension has a lot to do with sympathetic drive, and by ablating the sympathetic drive at the renal level, we are going to improve not only the blood pressure, but hopefully the insulin resistance as well as the sleep apnea. And just as we know that hypertension doesn't exist all by itself, like in Steno 2, the intensive therapy, controlled therapy did much better than the conventional therapy. We all must look at these difficult subset, try and do best with medication, lifestyle changes, and also a modality like this, which would give you better long-term results. Thank you for your attention.
Session is open for discussion. Sir, I have a question.
Yes.
What is the hospital stay required for this procedure, and what is the budget of this procedure?
Actually, it is not allowed by DCGI to be done in India. So on India, on routine basis, it's not done. It's available in Europe for almost 2 years now on regular basis. It is round the corner, but it has been round the corner for over a year, so we really don't know when it's going to be available to us. The budget expected is going to be about 1.5 because the catheter itself will be placed around 1 lakh rupees. So, but it would need just a percutaneous procedure, so I don't think it would need more than 1 day stay.
I request Dr. Ajay Dafle and Dr. Dhupe to felicitate Dr. Hiremat.
Oh, I already got a memento.
I request Dr. Karya sir to felicitate Dr. Ajay Dafle and Dr. Dhupe. I guess he's not with us. I request Dr. T.C. Rad. Our next lecture is on dyslipidemia, so I request Dr. Praful Kadu and Dr. Sanjay Agrawal to come on dais.
Good afternoon, everybody. Now you must be little less dyslipidemic after lunch. Also, the cerebral circulation might have improved. As itself, the dyslipidemia is a vast topic, and for we practicing physician, we have a lot many confusion, and there are few issues regarding the treatment part of dyslipidemia. So the issues are how long you have to treat this patient, whether patient who are having no other complication, asymptomatic dyslipidemic should be treated or not. Which drug? Simvastatin, atorvastatin, rosuvastatin. In what dose? How long? What are the effect? What are the side effect? Whether they are pro-patient, patient friendly, physician friendly, or pharma friendly. I think all answers we will get from today's speaker, who is an eminent diabetologist, academician, and so I think Dr. Shailaja Kai will answer to all these questions.
So good afternoon, everybody. Actually, this session was decided to be as a case discussion. So I am requesting Dr. Hiremat and Dr. Nitin Deshpande to join here. I also request Dr. Panikar to be here on the dais. Please be here. I am asked to arrange the chairs. Yeah. इथं पण आहे. You can be. Okay. So you sit here on this, but I can stand on the side. Yeah. Thank you. So typically we get a diabetic patient with a high cardiovascular risk, whether there is existing evidence of coronary artery disease or there may not be an existing evidence of coronary artery disease. But it's a high risk if there is evidence, increased mortality, and most of the patients will have proteinuria and nephropathy and compromised renal function. Most of them at least microalbuminuria above that and may have additional microvascular complications. So this gentleman, he is 53 years old and he has diabetes for 5 years. Blood pressure looks very normal. Stress test positive, peripheral pulses well felt. He is an obese individual, I think goes well with the name, and he is centrally obese same. He has a severe peripheral neuropathy. Looks like 5 years diabetes and he has developed microvascular complication quite a lot. There is no evidence of any retinal changes in the ophthalm checkup, but there is proteinuria, so it's about 200. So it has crossed the stage of microalbuminuria, and it is 600 microgram per milligram of creatinine, that is urinary albumin creatinine ratio. And we advise each and every patient should undergo a UACR rather than simple urine micral test. A UACR is a radioimmunoassay and it tests a microscopic amounts of albumin in a better way. So UACR is a better indicator, and compared to 24 hours urinary protein, if you are doing it still, it's better to shift to do albumin creatinine ratio in each and every patient every 6 monthly. The GFR is 74 ml, creatinine 1.1, uric acid 4.0. On investigations, he has sugars a bit high with A1C of 7.8, total cholesterol 169, HDL 29, a typical type 2 diabetic in India, LDL 98, looks like he is already on statin. TG is 240, with that A1C of 7.8, his triglycerides are 240. The non-HDL is 140 and SGPT is 44. It's a routine test which we do. So what is typical diabetic dyslipidemia? So we always say it is low HDL and high TG, but what do you mean by that? Low HDL, high TG, which is typical diabetic dyslipidemia, it means triglycerides are high, HDL is low, but there are more remnant lipoproteins which are triglyceride enriched, and so they are more atherogenic. LDL may be depleted of lipids, so it becomes small. So at the same LDL level, there are more small dense molecules of LDL, and we will come to that in short in that discussion, that how they are more atherogenic. And there is a decrease in the good large HDL. So the protective effect is lost. So this is typical, so it becomes more atherogenic. Now I will ask Dr. Hiremat that all the statin trials show that there is some reduction of the risk, and there is always a residual risk. That question is always asked, and I think it is much more in type 2 diabetics. Will you like to comment on that?
I think maybe Panikar?
You.
Me? Okay. I didn't get the question.
See, there is a risk reduction with the statins, suppose 35%. So why there are certain patients who do not respond to statin and the risk still remains?
Oh, that's because of the non-HDL component of the
So there are,
lipid profile.
so that's what, like, that's the point of discussion when we are discussing a case of a diabetes with the lipid abnormalities, that whenever we say that we reduce the risk with the statin, but still there is a residual risk, and how much we can address the residual risk is a big question mark, but it is there. And if you can see, when you are using statins in type 2 diabetics, the event is like what you are giving placebo in non-diabetics. So in general, event rates are high, and the residual risk is much more in a patient with type 2 diabetes in the statin trial.
So are we trying to say that 40% reduction is achieved with statins, and we need another 60% reduction to get to zero level?
So
how we
so
achieve
statins is not 100%. So you can't reduce everything with the statin. So there are some limitations. You want to say, please?
Basically, diabetes is a multifactorial disease. It's not just dyslipidemia. So you need to address all the things, and still ultimately everybody is going to die. So that risk is going to remain.
I think we are sticking to statins for,
Yes, yeah.
for today's discussion.
Yes, lipids maybe more. Yes.
Usually it is, the triglycerides are usually high in diabetic, that is the
Yes.
difference. So would you like to treat that?
Yes, I think that's the next part of my discussion. So let's fix the targets for LDL cholesterol, and I know as an interventional cardiologist, you will say below 70 even for a person who doesn't have evidence of cardiovascular disease. So your opinion on that?
Yeah, actually, we all say this gentleman would be in primary prevention because he has no evidence of coronary disease as of now. So I guess LDL target would be 90, maybe 100. We have come down from 100 to 90. So once you achieve that with whatever level of statin, I would feel that would be the optimum dose of statin.
His TMT is positive.
So once TMT is positive, there is about 70% chance that we are dealing with a true coronary artery disease. So if the patient is not going to go for an angiogram for confirmation, it could be a CT angio or a conventional angio. Let's assume that TMT positivity is 70% suggestive of a coronary artery disease. So we should assume that he's into secondary prevention. He has existing disease, and the target LDL would probably drop to around 70. So you probably need to adjust or readjust your statin dose. Are we also going to talk what statin? I mean, or